Okay, so on the back of the last session where we went through some of the principles of respiratory physiotherapy for bronchiectasis and some of the evidence base or lack of, I just thought it might be quite nice to pull it together with a couple of quick case studies. I've purposely not gone for new patient arrives in bronchiectasis clinic. We teach them the active cycle of breathing, and it's much easier to clear their chest because we know that, and that's really straightforward. I thought these two show quite nicely how we sometimes problem solve with patients when the basics aren't. So the first one's a lady who was 60 years old. She had known bronchiectasis and she was referred into our clinic from Ruth Green's clinic. She was struggling with increased infection frequency, and a physiotherapy review had been requested to ensure that her airway clearance was optimised. She'd had a CT scan 3 years previously, and that had shown bibasal bronchitis with associated mucus plugging. Her spirometry was normal. We had no bloods from when she was having these exacerbations because they were all managed by her GP, but in clinic her bloods were normal. She was having monthly infective exacerbations requiring oral antibiotics, and we also had no sputum samples. And that's because she reported a non-productive cough. It was non-productive on and off all day and all night, when well as when she was unwell. She never felt like she had sputum rattling, and she never cleared any sputum. She was doing the active cycle of breathing technique taught previously every morning and was clearing nothing and felt like there was nothing to hear or feel, and didn't really feel like there was anything down there. She's a farmer's wife with a very active lifestyle. She has no shortness of breath when she's well, but increasingly is breathless when she has these exacerbations. And digging in a little bit during those infections, she felt unwell. She was getting temperature, she was getting increased dry cough, but was still denying a rattle. So we'll always make sure that they sound like they're true infections. We get a lot of people who are reacting to being productive and having a cough, and actually there are no features infection, but that didn't really fit with this lady. She did seem to be getting frequent infective exacerbations. So when I saw her, she looked well. She was not breathless walking into the department, and she had a normal breathing pattern. As I said in the presentation earlier, the one thing we want to check when people have got a dry cough or a mixed cough is that they're not dysfunctionally breathing, and she very much wasn't. And she had this occasional dry sounding cough spontaneously when I saw her. I checked her active cycle of breathing technique, and she had a really good technique, and there were absolutely no audible secretions, just a slight increase in her irritable cough as she was running through it. She clearly needs a different technique. Now, we could move to adding in some positioning, but she's just not rattling, so it doesn't feel like that. And we could try an oscillating PEP device like an a cappella or a flutter. However, that's really useful when people have got very thick and sticky sputum, and she wasn't describing that either. And I wondered whether her dry cough was being driven by mucus plugging in her very small airways so that it wasn't rattling and bothering her, and the active cycle of breathing technique just wasn't getting into that. So I taught her autogenic drainage breathing, which the guideline tells us we can try when other things are failing, and we know has got a really good evidence base in cystic fibrosis. And autogenic drainage is really effective at clearing those small airways. So I got her to do some autogenic drainage breathing, and it involves breathing at different lung volumes to clear different parts of the lung. And as soon as I took her into expiratory reserve, so into low lung volume, breathing out as far as she I could hear a rattle at the end of the breath. And that told me that there was mucus in her small airways. So I taught her the 3-level autogenic drainage technique. It's quite a complicated breathing technique. As I've already said, it involves breathing at low lung volume to move mucus from the small airways, then to breathe at mid lung volume to move it up through the generations of the airways, and then we get them to breathe at high lung volume into inspiratory reserve to move the sputum up to the larger airways so that she can clear it with ease. And running through this technique, she cleared a small volume of green sputum. So this is a lady who'd had for years this dry cough and not been clearing any sputum and not felt any sputum. And we sent that sputum sample off. I advised her to do the autogenic drainage breathing twice a day, but to try different times of day and work out when is going to be the best and most effective time for her to clear. And we also went through some cough control strategies because she had this irritable cough as well. So her sputum grew haemophilus, and Ruth was happy to prescribe doxycycline. We advised her not to take it at that point, but to take it next time she felt like she had an infective exacerbation. So I reviewed her 6 weeks after that, and she'd not taken the doxycycline because she'd remained well. She was doing her new breathing technique morning and evening and clearing very small volumes of green sputum. The dry cough had completely resolved, as had the night cough, because she was now clearing those small airways. And a letter from Ruth Green 3 months later reported that she had no infective exacerbations since starting the autogenic drainage, which by this point was nearly 5 months, and her symptoms had significantly improved. So a very happy patient and a very happy team, really. So that's just an example of how we as physiotherapists will use different techniques for different problems. And when airway clearance isn't optimised, or when we suspect that there's retained secretions, we'll do quite a detailed assessment to try and work out what's driving that problem and therefore select an appropriate technique. So my second patient is also a lady with bronchiectasis, very similar age, 58 years old. This lady's a little bit more like a usual bronchiectatic patient. So she has Pseudomonas in her sputum and is colonised with that, and she grows occasional haemophilus. She has about 3 to 4 exacerbations a year for which she has oral antibiotics, and she has a course of home intravenous antibiotics most years, but only once. She cleared small volumes of yellow sputum, which cleared really well with the active cycle of breathing technique, and she had really good compliance with that and did it twice a day. And she also attended the gym 2 to 3 times a week and had really good fitness levels. So your model patient. So she came to see the specialist nurses and myself as a ward attendant because she was really struggling. She was struggling with significantly increased cough. This cough was really irritable and tickly. She had increased sputum viscosity. It was incredibly thick and sticky, and she was really struggling to clear it. Her white cell count was 12 and her CRP was 50, and she was fatigued and pretty fed up with it, really. She'd already taken oral ciprofloxacin with minimal improvement, so therefore she went home with an intravenous tazocin for her, and she administered herself at home. When I reviewed her, I checked her active cycle of breathing technique, and she had a really good technique. She did clear a small volume of thick sputum, and we just discussed the usual advice really to increase the frequency of that, make sure she's drinking plenty. And what usually happens with most patients is once they've had 48 hours or so of the intravenous antibiotics in their system, their sputum just becomes much easier to clear, and the increased frequency of the active cycle of breathing is enough to clear that. However, she had her 10 days of IV antibiotics, and really there's little improvement in her symptoms. She still had this ongoing cough. Her sputum was still very sticky. She was really rattling at night, but was struggling to clear that even with the active cycle of breathing. She now developed an increasing chest tightness, and she felt like her left lower lobe was aching. We repeated her bloods and they were all back to normal, and at this point she had a chest x-ray and there was nothing new on the chest x-ray. So I reviewed her active cycle of breathing technique again, and she cleared very thick sputum with difficulty, but during that technique she was very wheezy. She had audible, high-pitched expiratory wheeze. In that circumstance, we modify her active cycle and make sure that she's using a gentle technique, but she was still wheezy. She was also very stressed with her change in symptoms and her lack of improvement with intravenous antibiotics. So we then advised active cycle of breathing technique in left side lying and left side lying a quarter turn supine, just to try and ensure that we were maximising ventilation into that area where she was aching and where she felt the rattle was. So as per the guidelines, we've now added in positioning. We made sure her technique was very gentle so that she wasn't increasing her bronchoconstriction. We went through some cough control strategies, and we gave her a salbutamol inhaler to use pre-physio to try and reduce some of that bronchoconstriction to make her sputum easier to clear. We also took a sputum sample which grew Pseudomonas again. So 2 weeks later, I reviewed her again, and her wheeze was a little bit better, but her other symptoms were unchanged. She was still really struggling with clearance and cough. Her sputum remained extremely thick and sticky. Her bloods were normal, so there was no active bacterial infection. So I commenced bubble PEP. So bubble PEP is a form of oscillating PEP where we get people to blow through a straw into a bottle of water. It's a makeshift oscillating PEP, which we can obviously have immediately to hand, and it's useful to try to see if it's effective before we provide an a cappella or something a little bit more permanent. And I advised her to do the bubble PEP in sitting and in left side lying. And a week later, she emailed me these. So the picture on the left is the first picture that she sent through. I get lots of pictures like this and photos like this. And she's clearly now coughing up casts. But it was difficult to know the scale of that. So the right-hand picture is another sample, another cast, and you can see that it's really quite long. So we got a pot to her and we advised her to get one of those casts and to keep coughing till she cleared one, or keep doing her bubble PEP and her inhaler till she cleared one. And we sent that for microbiology, including mycology, and it grew fully sensitive Pseudomonas, Candida, and as I expected, Aspergillus. So when we're seeing people clearing casts, plugs, little black pips we sometimes see, we'll always send that for extended fungal cultures. But her ABPA screen was negative. It's not ABPA, it's Aspergillus bronchitis picture. So she had a repeat CT scan, and that showed her generalised bronchodilation, which she had before, and thickening with mucus plugs in the lower lobes. But she did have this soft tissue nodularity in the left lower lobe and left upper lobe, suggesting active infection. And given that we'd given her intravenous antibiotics with minimal improvement, and that she was clearing casts, and that we'd grown the Aspergillus, it seems that the Aspergillus is the culprit. I hope those two case studies just give you a little bit of an idea about the thought processes that we go through and the way that we escalate our management until we get an improvement in symptoms, and we try and we work out what's happening, and give you a bit of insight into how we work as physiotherapists, really. Thank you for listening.